Hi. Hi. My name is Molly Weibel, and I volunteer for the Northwest Epilepsy Foundation. Today, our medical panel will consist of Dr. Evans, Dr. Dempster, Dr. Toub, and Dr. McBurney. If you have a question for one of our panel members, please form a line behind one of this standing mic, and ask your question from there. Thank you.
I can make a comment while we're getting people to come up. One of the points I wanted to make in my talk was GW Pharma elected mainly due to doing the science and regulatory issues to study cannabidiol pure in isolation. It is not established that that's the best way to use cannabinoids to treat seizures. And in fact, there is some anecdotal evidence to suggest that it is that complex mix that is necessary for the full action. So just to make that point. So that's another aspect of the complexity that I was alluding to at the end of the talk that will be a methodological challenge potentially going forward.
Question for Dr. McBurney. I just wrote down that CBE enriched cannabis. You were talking about that, and my question is, at this stage of the game,
Right.
can you smoke it? Do you vapor? Do you food? What does it matter? The ingested method about this?
Well, you did, but we have people on the webcast that we need to.
So we were talking about CBD
Right.
Enriched cannabis, and I'm wondering at this stage if it comes in all forms,
Yeah.
and what's the best?
THC that there are problems due to first pass metabolism with, which means the metabolism after substance is absorbed from the gut and it has to go through the venous circulation through the liver, that result in the generation of very psychoactive, long half-life breakdown products, Delta 11 THC, which has like a 2-day half-life and is dramatically more psychoactive than the Delta 9. So the pharmacology can be pretty complex, especially with ingested. But for CBD, they've elected to do oral. It's hard for me as a...
And when you say oral, does that mean that you eat it, or you mean
well,
it's...
it's usually extracted and then it's fat. It's a fatty substance. So then it's put in like sesame oil. And then in a gelatin capsule. So that's typically how these oils are handled. But for the neuropathy studies, because they didn't want to have people combusting it or burning it, smoking it, they did vaporization, and it turns out that the cannabinoids will actually vaporize at a temperature below their combustion point. So that's actually a very reliable way. And blood levels are achieved within a minute or less with inhalation of vaporized cannabis compared to several hours with oral ingestion.
And all of that, if I understand correctly, is available now, yes, but it's doctor-directed, or
No,
it's completely illegal
I think
still.
it's very difficult for a physician to directly direct somebody to go to the dispensary and get something. I view my role as providing some level of education. Is this reasonable in the context of your overall treatment plan of what we think we are accomplishing or might accomplish with standard anti-epileptic drugs? But I can't write a prescription for medical marijuana. I can simply provide an educational resource. If patients want to access an herbal remedy of that nature or any other source as part of a self-care program, then I try to give them the facts, just like I would if they wanted to ask me a question about, using St. John's wort for treating their depression instead of an SSRI. Now that would perhaps change depending on subsequent developments in research and removal of cannabis and cannabinoids from Schedule 1. So, yeah, it's a time between stories, to quote Charles Eisenstein. We really have a narrative of prohibition, and we have a narrative that's after prohibition, and we are hung up in the middle.
Right in the middle. Okay, thank you. I have some more questions unless somebody else wants to ask right now. Dr. Dempster, I'm wondering about extended release versions of medications. So are we at a point in time where most of the medications can now be time released, or only a few?
So it's getting better, making something time release, the technology to do that, when it first became available, was big business. And now it's certainly a lot easier and a lot cheaper for some compounds, like extended release topiramate, oxcarbazepine, the new ones I'd said. There were extended release versions of levetiracetam and lamotrigine. They've been available for quite a while. But an example to the contrary would be ezogabine, retigabine. It has to be taken 3 times a day, and it probably has to do with the solubility of some of these compounds and the absorption. So there are still going to be idiosyncrasies to different compounds, but it is to the side where there are more than less available. And the advantage is, again, just avoiding the peak plasma concentrations that tend to do the damage. But apart from avoiding side effects, which can be deleterious, because if you have side effects from one drug, you can't get the other drug. If you're trying to use a couple of drugs in concert, you can't get polytherapy really pushed to useful levels. If, let's say, your immediate release carbamazepine is causing you to be feel sick 3 times a day, you're not going to be able to add zonisamide or something else at a meaningful dose. So the short answer is that yes, most drugs are headed that way. There's nothing but financial interest on part of pharma, because they're able to extend patents on some drugs, and then there's for the generic manufacturers, they have a more attractive marketing strategy, but it's also better for patients.
Right.
And so it is sort of a synergy. It's a win-win for everybody, and the cost has become far less prohibitive.
So it's follow the money on the one hand, but it's also keeping the level steady.
Right.
Meds.
It's a happy coincidence that what allows pharma to continue charging more is actually often makes a better product. Because again, the efficacy is not necessarily demonstrated to be greater milligram per milligram, but if you can get someone to tolerate a higher daily dose and an overall higher peak plasma concentration throughout the day, the area under the well, I won't even get into the end of curve stuff, but if you can get that higher, generally, if you believe how anticonvulsants work, it should be effective, and so it tends to work out better. But if you forget your dose of medicine and you only take it once a day, you could be in more trouble. So there's still no perfect answer. We still have to take pills, which I think is hopefully we'll have something better than that in 50 years.
So I'm assuming that if and when they are available, that would be the drug of choice. It would be a time released would be the drug of choice. So a physician would automatically prescribe.
Can I make a comment on that?
No.
Sure.
Unless
I'll just comment on that. So I'm a fan of extended release as well. Patients like it once daily dosing, or I still dose it sometimes twice a day, in fact, just to keep those serum concentrations as level as possible. But I've had quite a few patients, we try and give them the latest and greatest, or we try and give them extended release, and they don't do as well. Some patients actually have, for whatever reason, are not as well controlled, and they end up going back to what they were doing before, or we try something else.
And I don't tend to start with extended release. I still, people are usually able to take medicines twice a day.
Yeah.
It's usually cheaper. Zonisamide is a great example of a drug that is only available. It is extended release. The half-life of it is about 63 hours.
And acylcarbazepine.
Yeah, acylcarbazepine. But so the formulation, as they exist in nature, just like extended release Dilantin or Depakote, they really can be given once a day. Again, you can get some improvements probably by giving those even twice a day. But for a drug like lamotrigine, I don't start with the extended release version. Like you said, it tends to not be well absorbed. And there are actually bioequivalence charts that you can get for drugs like Depakote ER. I always use Depakote ER, but you have to realize that it may only be 75% as potent as the direct release. So they're not all created equal. The one extended release drug may not be as useful as the next. Some of it is an innate property of the drug anyway, so they didn't have to do it. Gabapentin is a great example of a nightmare drug to dose for epilepsy. Probably, 80% of people can have good compliance with a TID drug, something like 80 or 82%. And nobody has moved to make gabapentin extended release for, oh wait, they have, but you can't use it for epilepsy, right? And it's extremely expensive, and it's only approved for treatment of neuropathy. So each drug you kind of have to take case by case.
Thank you. I think I understood about 50% of that, but thank you for answering. I have one more question. Would you mind if I just ask that one? Oh.
Go for it.
All right. Okay. This has to do with the concept going forward when we think about the vision for the future of drugs. And I'm wondering if we're on our way to have the ability to have a designer drug approach.
Right.
In other words, it's just like we're doing what I understand with cancer, is that it's less and less one size fits all and more DNA and this and that, and then they find a designer drug. Is that what's in the horizon?
We're a lot further from genetic-based therapies in epilepsy than we are in cancer. A lot farther. Dr. Sergino actually wrote an article for an editorial for Epilepsy a few years ago called, it was like the end of anti-epileptic drugs, because it's like we've gone about as far as we can go and there's not going to be anything else. Well, and he's one of my favorite epileptologists, but anytime you say never, you're usually proven wrong. So the new direction out of the chart that I had of things that may actually turn out to work are called neuropeptides. So they're proteins that will probably be able to more specifically target areas of brain that are generating seizures. Problems with those drugs are that they have very potent effects on endocrine systems. You can end up making people really obese, really tired. So that's in its infancy, but there's some exciting stuff on the horizon for neuropeptides, and those may provide a more targeted way to get the drug where it goes. We just Keppra is our first drug that was developed in a targeted way to target epilepsy in the temporal lobe. So that's been on the market. I guess, when did Keppra get approved? Yeah,
99.
Yeah, something like that. Late 90s. So we're just starting to figure out how to do this. We have to develop models first for epilepsy where we can make a rat look like they're having a seizure that happens the way that humans have seizures. The way that we do it right now is not really the way that we cause animals to have seizures to test the drugs on is not always very similar to the way humans have seizures. So there's a lot of basic science that we have to learn about epilepsy. But you're absolutely right. I mean, that's the next step things will be at, hopefully, beyond just a new flavor of sodium channel blocker.
Thank you.
There are some genetic tests that we do need to run, and especially the Asian population, if we're going to use a medication like Tegretol, because it can be associated. If you have that specific gene, then you absolutely should not use medication like Tegretol, or you could have an adverse reaction. So we don't have anything to cater towards the patients, but we are getting a little bit more information on if they're at least right now of Asian descent, and you're considering Tegretol, you should check this blood test. But pretty limited.
Although if you have to be on Tegretol, you probably can't afford genetic testing because it's usually a pretty inexpensive drug.
Guidelines.
Yeah, guidelines.
My son, Joel, has cerebral palsy and has seizures that are pretty hard to treat. We were a little bit, I don't want to say depressed, but we saw the list of drugs, like, yep, that one. So we've been through quite a few of them. So we thought we had a home run because he tried the modified Atkins diet, and that seemed to really help for a while. And now, efficacy has dwindled, and so we're going to try ketogenic diet next. But it said on there, like, most of these diet therapies are done for like a couple years. Why wouldn't you do it for a long time if it worked?
Yeah, that's you.
Yeah, that's kind of me and you.
Yeah,
We don't use them tremendously in the adult population for most. So I think most of the data is with pediatrics. The diets are hard to follow, particularly ketogenic diet, and the diet can actually have some long-term consequences on organs and cause like pancreatitis and things like that. And so generally, I believe that the efficacy is felt to be over a short period of time, and then beyond that, the risks kind of outweigh the benefits. But maybe you can kind of add to that a little.
Sure, just the long-term side effects. Very difficult, number one, for anyone to follow that diet. If you're feeding a child, then it's more reasonable. But we do have dietitians, and I'm sure some of the other panel members as well, that you work very, very closely with, and you do this under a controlled setting. And a lot of the data with the diet specifically through the modified Atkins is coming through Johns Hopkins University. Mm-hmm. And then the low glycemic index treatment is through more Massachusetts General. And then the ketogenic diet information's been out for a while, so different centers doing that. But like Dr. Toub said, it's more kind of the long-term end organ. So you're you're eating ketogenic diet, 90% fat. I mean, it's a very, very hard load on the pancreas, on the cholesterol. So you're setting yourself up for other long-term consequences. But if you can really calm the epilepsy down, quiet things down with the diet for a year or two, the hope is that either your body, your metabolism is going to change. You may become more receptive to other medications. There might be new medications out on the market. Mm-hmm. But the data is a couple of years, and that's with any of the trials. All these drugs are getting approved for even the marijuana stuff. I mean, they're talking like 12 weeks, and they're throwing out this data. So to have data for 2 years is actually a lot.
Yeah, maybe I'll get him through puberty, because puberty seems to have wakened everything.
Yeah.
The other question is so his seizures, I mean, they happen a lot all the time, but in the mornings is a really, like, that transition between sleeping and awake is become a really exciting time of day. And he starts to have a series of seizures sometimes in the mornings. Is that a time where the body it's harder for the brain to function? Or I don't know what that means, but all I know is with him, if I don't get in there as soon as he wakes up and start helping him, he could have seizures.
The brain is this rhythmic organ that has your brainstem and then the outer part, right? And there's this really special connection that's a system that most people don't talk about. These are called thalamocortical networks, and they synchronize in different ways throughout the day to sort of shift your state. It's kind of the transmission of the brain, and it shifts you into different states of consciousness through the program to go into drowsiness and different stages of sleep. And transitions from wakefulness to light sleep are when people are really vulnerable for having seizures. And I would also say that it really doesn't tell you what kind of seizures people have always. I've seen people clinically diagnosed with genetic forms of epilepsy because they have their seizures when they awaken. But the fact that your son has, I guess, a developmental delay and is responsive to a ketogenic diet makes you wonder if there's a genetic form of epilepsy that might be testable, and sometimes in those cases it might be worthwhile to get it. We'll be able to get people's entire genomes sequenced for $1,000 in the next couple of years, and I think that's going to help at least give a name to some of these things, so your doctor can say, oh, you turn out to have this version of Dravet syndrome or something like that, and so at least we can kind of let you know what to expect a little better and maybe target the therapies a little more. So maybe your kid ends up on stiripentol and clobazam instead of going through all these sodium channel blockers, or
Right.
maybe cannabis. So.
And just to add to that, there are a lot of different types of epilepsies that probably have some sort of a genetic basis, and we just don't know what they are.
Yep.
So when we do these big genetic screens, we're testing for forms of epilepsy that we know exist that have an identifiable gene. So if, 15 years down the road, these screens are available, we really can only pick up genetic forms that we know exist and that are linkable to. So just because we can't say we've identified a genetic abnormality, that doesn't necessarily mean that there isn't a genetic basis.
Okay.
You have a big target gene.
Yeah,
study.
just one
Like,
more
didn't
thing
pan out.
quickly. So seizures are more common during transitions, but at the same time, your son waking up from sleep, it's been 12 hours since he took his medication last. So medication levels do drop over time, and so that's something that needs to be looked at and make sure. It probably is a sleep transition effect, but medications are lowest right before you take your next dose. So the medication and the timing is important to look at.
Yeah, it can be as easy as making sure you give it right at bedtime. Of course, then you don't want to wake a kid up to give them medicine, because then they're sleep deprived and then they have seizures. So.
Or even giving us a higher dose at bedtime so that the level is higher at bed and it doesn't quite drop as low before he gets his next dosage.
So we do have some people on that are live stream, and this is to you, Julia. It's something you said, and I didn't listen to see if you answered this yet, so I want to make sure this gets answered. Did I understand correctly that you believe the risk of surgery, probably multiple surgeries, is lower than trying one of the diets, which are essentially reversible?
No, that's not correct.
Okay.
Yeah, so surgery obviously carries quite a bit of risk. The reason that we offer surgeries to patients that have highly focal identifiable foci is that it's potentially curable, a curative treatment, whereas epilepsy diets really don't cure the underlying problem, but it's appropriate for patients that would otherwise not be good surgical candidates. So for instance, if I have a patient that is a surgical candidate but really is averse to surgery and isn't interested, we would still be able to offer that person diet therapies.
And focal epilepsies probably aren't as amenable to dietary modification from the data I've seen. I'm just saying from the Hopkins data and the stuff I saw at last AES, but it's worth trying. Yeah,
Sure.
I'd try it.
I probably would too. And patients are adverse to surgery and even medications, and if there's something semi-natural, these diets can be effective. It's worth a try.
Good. Thank you. My question's for the panel. I'm a nurse, and I was educating my patient about psychogenic non-epileptic events, and I find there's very few resources that de-emphasize the word seizure. So how can we educate these people with this bombshell diagnosis without using the word seizure? And what resources are you using to educate your patients about psychogenic non-epileptic events?
So we actually, exactly. So we take the word seizure out. I tend to refer to them as either paroxysmal non-epileptic events or behavioral events, and changing that word seizure to events, I think, is kind of the first stage. The other step is the harder step, which is finding access to treatment of these. And really the only therapy that has been proved tried and true to be at least somewhat effective is cognitive behavioral therapy, and that's gaining access to the community to psychologists that have that sort of training. I think the mistake that is made is, the common nomenclature is pseudo-seizure, which implies, I think, that patients are faking. And I think the vast majority of these patients, it's not deliberate. It's just a physical manifestation of a psychological disease. So I think it's just a shift in frame of mind and getting people the access to the resources that they need, which I think is probably the biggest challenge.
Yeah. That's kind of a catch-22 because patients with that diagnosis are often from tough backgrounds, and yeah, we certainly don't have the funding, as you know, in Oregon and Washington for mental health.
Can someone on the panel just really quickly, for everyone listening in the audience and on the web, just what PNES is? What is pseudo?
So I briefly touched on with the diagnosis initially, but so it's PNES is what we often see in the literature. It stands for psychogenic non-epileptic seizures. I like to use the term spells. So I still use the PNES, but I don't say seizures. I say psychogenic non-epileptic spells. And they are a true psychiatric illness. It's either a conversion of an emotion into a physical symptom, or it can be a dissociative state where something traumatic's happened, something is brought to remembrance of the situation, patient detaches themselves. So they can actually lose awareness. So they are detached from the situation. They may even not remember the situation, which is, there's a whole other issue about driving, and they're not epileptic, but they're still losing awareness in a different reality, and those patients should not drive. So, but to answer your question, I say spells.
Good. Thank you. I had to actually cross out seizures in the handout that I gave a patient now. Just separate that, because then they're exposing themselves to the risk of all the medical treatment that comes with seizures. So it's a unique challenge. Maybe the panel can come back next year with a nice pamphlet for this problem.
There are books and there are panels.
What I think would really be the challenge as we go toward different ways of financing healthcare with accountable care organizations, which are truly the latest way to capitate care, because patients with non-epileptic events often consume large amounts of resources and very ineffective and dangerous treatments. To develop special programs with access to both social support services and access to treatments that is internally funded by not wasting money on ER visits and ICU stays and the occasional person who gets intubated because they got too much Ativan by EMS and then in the ER. But that would be something that I think, even as a sort of a cooperative metro-wide endeavor out of this mental health effort that's a cooperative endeavor with both Legacy and Providence, that we could potentially look at identifying those as individuals who are deserving of intensive help.
Excellent.
Yeah, and actually,
Dr. McBurney.
Sorry.
Someone that is very interested in that is, and I don't know if you're familiar with her, but is Dr. Victoria Wong. She's very interested in helping. She's up at OHSU.
Yeah.
And with Zelinsky. And so she's one that's very interested in creating something that can give them a platform, if you will. So I think that, and we need the help too, because they come to us and we don't have the resources that we so need to help.
I will say that when I was a fellow with Dr. Zelinsky at the VA, and we became the Epilepsy Center for Excellence for the region, and all the epilepsy monitoring consults got referred to us, I never saw one more case of anything but psychogenic non-epileptic events for the last 6 months of my fellowship, unless I was at OHSU, and it consumes a tremendous amount of resource. And Dr. Zelinsky was actually able to finally show the VA how much money they were spending on these patients to get funding to actually start doing some research. So it's the elephant that's in the room, and for a lot of epileptologists and centers that we still are grappling with, I think, everywhere.
Well, and the original concept of the Comprehensive Epilepsy Center that came out of NIH back in the late 60s and early 70s, a key component of that Comprehensive Epilepsy Center was social work. And that is, with the reductions in overall reimbursement and funding, has been the first thing to go away, and that's really, really what we need. We need epilepsy-informed social workers with some group therapy backgrounds and also who know where the social support agencies are to get people help, because the associated psychiatric comorbidity with non-epileptic seizures is often precludes, it's associated with extreme negative social mobility and poverty. And so these people are, they're caught in the social safety net, but they have very few resources.
And the last Cochrane review's done, they did one in '05 or something, and then they just redid one, and we still don't know how to treat them adequately. Like Dr. Toub said, the best evidence is for cognitive behavioral therapy, but there needs to be a lot more funding because these people are suffering quite a bit. Right. It's a terrible disorder to live with and for the families, and it's a very dangerous problem.
I think epilepsy is a really hard problem. I think non-epileptic events are dramatically harder, and they go to the bottom of who we are.
And I believe that when I'm working with the community, not only are they difficult for the community and the families themselves, but also for the police and the fire, because they don't know how to respond. They don't know what's happening. So, Kurt, go ahead.
Dr. Toub, in your presentation, you showed a slide that had a couple of the medical devices that are available to people.
I kind of glazed through quickly at the end. I was running out of time, so I apologize.
Right. Okay. Well, one was a VNS, which I think probably most people are familiar with. And then the other one was that intracranial.
The RNS.
Yeah, yeah. How long has that been around? How many patients have that? And if it's really only as effective as a VNS, why would anybody want one?
That's a great question. So RNS has probably been around now for coming up on about 2 years, would you say?
It came out at AES in D.C., so December before this.
Yeah, so about a year and a half. It's been around for about a year and a half. I think that, like I alluded to, the science behind it sounds like it would be this wonderful, earth-shattering idea. I mean, the concept of actually being able to detect seizures before they happen and thwart it. It's a closed-loop system. It sounds like a great idea in practice. But unfortunately, at least the data that we have available, and because it's such a new technology and it's really not readily available at most epilepsy centers, I think the closest center where it's actually being implanted here is actually Swedish, up in Seattle. And so we don't have tons of patients that have it done. Currently, is exactly as you said, I find it hard to justify recommending an invasive surgery like RNS unless somebody already has had a VNS device and they aren't.
What about the battery life on that thing?
The RNS? I don't know about the battery life. I think a lot of it, similar to VNS, depends on, for the VNS, for instance, how often you're swiping it, what the settings are. Similarly, I would imagine that you would need to be concerned a little bit about how many seizures the person is having, how often the thing is firing. But we're not an implantation site, so I'm not exactly sure how long the battery life is.
It's like 2 to 3 years. But I would say, Kurt, that there are also gigantic machine learning projects that have started using recruitment over globally for these people who just like to play with data to build predictive algorithms to detect seizures. That's one of the challenges with RNS, is for the machine to learn your seizure. And that's still just barely ready for prime time and has the potential to get a lot better. They gave a $25,000 prize to groups around the world who wanted to have teams and do this kind of algorithm building, and they got more data than NIH got with $40 million worth of grants over 25 years. Yeah, in a 3-month period.
Several thousand nerds working on this problem in a group of teams. Yeah. And they very, very rapidly made progress, and these data sets are posted online. There are several hundred seizures recorded in spontaneously epileptic dogs and also in a handful of humans. And they just basically play with the waveform characteristics and frequencies and things. And pretty soon they were able to, with 85% accuracy predict before the seizure start when it was going to start.
By making a scoreboard. These guys just want to jump ahead of each other, there's often a disconnect between medical equipment manufacturing and what goes on in the rest of the world. The computers that we use in the hospital are tens of thousands of dollars, but it's like the equivalent of something you can get at Best Buy for $99. So as we recruit, as we recruit, I think the best minds into it. I think we're gonna get really a lot better with it. So it's not like VNS. VNS can only work kind of one way. There are different stimulation parameters, but I think RNS has room to grow. It's just not so impressive. Same with deep brain stimulation. I think if we can find the right targets, it's just going to take a while.
Yeah, the one thing that I can comment on is from feedback from the Swedish folks is that we gather a lot of data and people actually are having a lot more seizures than we're recognizing, and they're asymptomatic. And we don't really know what to do with this information because we don't want to just be snowing people with tons of medications to try to eliminate every single electrographic seizure when it's not affecting them clinically. And so when a person is reporting, 2 seizures a month and they have this device in place and they're having 3 a day, what do you do with that? And so I think there's really a lot that we really don't know about what to do with the data that we're gathering from the device. So right now, I don't know about everybody else, but if I have a patient that's intractable, doesn't want surgery, or isn't a candidate for surgery, I would probably recommend VNS over RNS.
Yeah. Plus, you can't get it. You can't get there from here.
My question is regarding cultural differences. I am a school nurse, and so that's my milieu. I see these kids in school, and I have issues with parents who are really non-compliant with medication for their children, trying to convince a parent whose son suddenly has a huge spike in the amount of seizures and trying to convince them that maybe it's related to the boxing that he's doing multiple times a week, or the student whose mom doesn't realize that taking the medication for her absence seizures is important. She went from an AB student to a CD student when mom decided the absence seizures didn't exist. Is there any kind of data out there, culturally sensitive data regarding students of different cultures, and how can I as a nurse and how can you as professionals help parents understand more the need to be compliant with medication?
It's a great question. Personally, I think culture is a big part of it, but regardless of, I may have a very different frame of mind than this lady sitting right across from me. So I think we really need to just listen to people. I think the best thing that you can do as a nurse is just kind of reiterate that they really need to speak with their physician, because it's really one of the biggest parts of our job is to just educate patients and do the best that we can to explain to them what the ramifications of having ongoing seizures that are not well controlled, what that can do. And that's the best we can do. We can't force people to do things, but education I think is kind of the first step and probably the biggest thing. And even just simplifying things, taking away all the medical jargon and just drawing pictures and explaining to patients and their families this is what's going on.
And for you, have you ever heard of a book called The Spirit Catches You, You Fall Down?
Yes.
Yeah. And I think that's just a great illustration of how far we can go wrong if we try to forcefully confront these things in the wrong way. Because you have to keep them in your office for them to hear what you have to say. So I think you keep fighting the good fight. But we had this discussion among our pediatric group. I did with our peds group a couple of weeks ago. Oregon is a lot more permissive. I'm from the South, and you do what the doctor says to do, for better or for worse. But out here, there's certainly a lot more leeway even with your kids. And I think where most people are drawing the line now is they're calling Child Protective Service, and this is where my line is. If kids are having generalized tonic-clonic seizures and the parents refuse treatment, because that can kill a kid. Mm-hmm. And that's, it's really hard to walk that line to not alienate the parents, which makes the kid worse off, versus, risking a kid dying from epilepsy or being, one of my first people I saw out here had gelastic epilepsy, which is a really funny, really usually pretty treatable syndrome, but the parents had taken him to a naturopath for so long they had completely uncontrolled epilepsy and had developed hippocampal sclerosis from it and was becoming demented. So, there's harm in allowing all sorts of seizures, even uncontrolled complex partial seizures of mesial temporal origin. There are a couple of Italian studies looking longitudinally at brain structure, and your brain shrinks up to 5% every couple of years. The hippocampus can. So all sorts of seizures need to be treated, or you have worse long-term outcomes. So you got a tough situation, and I have a friend of mine from Arkansas who's just as a school nurse asking me what to do the other day, and I just realized, God, I don't know. It's really hard.
Thank you.
Yeah.
Well, I'm from Arkansas as well, so I guess we're
Oh,
just
wow.
representing tonight.
All right.
But, during my time at Hendrix College, I might have developed some liberal inclinations. So
Me too.
someone I heard mention stigma briefly in their presentation. As someone with epilepsy and someone with a degree in anthropology, I see it as being a less pressing issue for me personally than just finding a way to stop losing my consciousness at random. But I found in the past few years that something that also had a huge impact on my life was just facing stigmatization out in the world. I mean, when you're 25 and you're losing your consciousness at random, sometimes that involves wetting your pants. I mean, sometimes I found myself getting kicked out of comedy improv classes. Sometimes I found myself being told that after having a seizure in a yoga class that I attended, there was a vote being cast as to whether or not I should be allowed to return to that class again, because as you can imagine, whether or not you witnessed the seizure, it's a pretty, perhaps a stress-inducing event for those surrounding the situation. What might be some of the first steps we can take to try and work around these stereotypes, this kind of discrimination of sorts that I found myself facing?
This is one, epilepsy awareness. And I think that the more people that we're able to get out to these conferences and listen online and come to the walks and recognize that epilepsy is much, much more common and much more complex than simply seeing a child writhe on the ground in an epileptic fit. So that's what most people have in their mind is epilepsy and the stigma that comes along with saying, I have epilepsy. And that's the picture that they have in their mind. So to personalize that and say that you have epilepsy and
to share my vignettes about wetting my pants in my late 20s, yeah.
you're a functioning individual and you have a higher educational degree and you're smart and you're out in the workforce and that's important. And to break down the stigma is really education.
People are afraid of what they don't know. So the more that you can educate people around you, the more likely it is that they're not going to be afraid or offended by what they see. I know that's a hard thing to do, but if everybody does their part, then over time, hopefully the level of education in the public will be better.
All right, so here's a face to it, y'all.
Thank you. Yeah. Another question from online. My 10-year-old has focal epilepsy and mild CP. Due to cortical dysplasia in the temporal lobe, some seizures cause a short inability to speak. Does that necessarily mean the focus is an eloquent area?
That's a great question. Probably not one that anybody sitting at this panel will be able to answer without having more information. And so really, people can have different symptoms during their seizures. It depends on where the seizure spreads. So when I talk to people about epileptic focuses, And some people say, well, I never had a grand mal seizure until 3 years ago, and I just had these other spells before. I kind of liken it to dropping a drop of water into a puddle. And if you drop it really close, it only ripples a little bit, and then you drop it from far away and it ripples further. And so what people do during their seizures really reflects where the seizures are coming from. Whether the speech problem is something that happens at onset, or whether or not it's a late manifestation in the seizure really is important to know, because if the speech can be affected late in a seizure if that's where the seizure spread to. But if it's not originating from that area, then potentially it's a resectable focus if it's not.
Yeah, if it's a focal cortical dysplasia in the temporal lobe, it absolutely needs to be investigated for a resection because,
Yeah, so what I would say is it's a great question, but that's something that really needs to be addressed by their epileptologist.
So my name is Wendy, and I have a 24-year-old son who was diagnosed with a seizure disorder a year ago this month. My question is that he was an identical twin. His brother died at birth, and the diagnosis was amniotic band syndrome. It was a 1 placenta, 1 sac pregnancy. Is there any chance that this is all related to that? Has there been much research?
twinning is a risk factor for epilepsy.
Oh, really?
Uh-huh.
Oh, I did not know that.
I didn't know it either. Sergino taught me that. Actually, it is apparently a risk factor. Twinning is stressful.
It's not supposed to happen. It's a mutation in science.
Right, but the actual process of a twin pregnancy, there are lots of vulnerabilities that can happen, and so there can be very small injuries that can be of consequence, is what I would say. Maybe other people on the panel have.
So just be
something to say.
twinning, not the amniotic band.
Right, but I was just wondering because it just seems so weird that this would all happen.
Thank you. Yeah.
Well, except that if you live to be 70, you have a 10% chance of having a seizure sometime during your life. And, over 2% of the population has recurrent chronic seizures during their lives, and at any one point in time, 1% of the population has epilepsy. So it's just really common. And, in my family, my father had post-traumatic epilepsy, and my youngest brother had a Nintendo-induced seizure one morning playing his son's Nintendo after he had probably had a couple too many beers the night before. So, there's probably not a person, that they're really honest, that has not had their lives in some way affected by epilepsy, but people don't talk about it. They keep it quiet, and that gets to this whole idea of stigmatization.
Hi. So this is a question, I guess, for Dr. Toub primarily, because it goes back to your presentation. I was just hoping you could paint a little bit more descriptive picture of who would be a good candidate to get into your EMU. I think the only thing that I had heard, and I didn't see the beginning of your presentation, so maybe you addressed that. The only key point that I heard was that a patient may not be having adequate seizure control have possibly tried 2 medications. So I'd imagine it'd be much more complex than that. But
yeah, so my kind of description of the EMU was in the context of patients that have medically intractable epilepsy, but in fact we use epilepsy monitoring unit for all sorts of purposes. Generally, if I get a patient that I see in clinic, if their story's pretty good, I'll usually try to treat them with medications. If they don't respond to medicines, or if when they come in their spells are kind of wonky and I'm not really sure if they're epileptic or they're not, that would be an indication for a monitoring unit. So I would say probably 75–80% of our patients that we put in the monitoring unit are actually for the purpose of diagnostic purposes to figure out what's seizure, what's not. Or we know they have a seizure disorder, but we're trying to figure out exactly what type of seizure disorder they have. And then the other kind of small percentage would be the medically refractory patients that we're trying to see if they're amenable to a surgery.
just in your mind, do you have like a time frame for how long these patients may have been refractory for, or how long they've been experiencing seizures? Maybe how frequent and how frequently per month they experience seizures?
Are you're talking specifically about the medically refractory population?
Yes.
I don't think that I have any like definite paradigm that I follow, but if I have a patient that I see in clinic and I've had them on 2 different medicines and I haven't already characterized their seizure disorder, then at that point I would be have a very low threshold for referring them to the monitoring unit.
Thanks.
Yeah, I would say epilepsy monitoring is something that's done far too little in the U.S. rather than too much. So most people err on the side of not referring people for monitoring, and you'll be shocked at what you see a lot of the time.
That's underutilized, utilized late, and consequently, epilepsy surgery is utilized far less than the epidemiology suggested it should be, and it's utilized far too late. People have been, on average, suffering with uncontrolled seizures for a decade or more usually before they are considered for surgery, and the answer was there within a couple of years.
Yeah, just to like add to what he said, we like to try to pinpoint good candidates for epilepsy surgery early. There are dangers to having seizures that go on for long periods of time. If patients, for instance, have one focus early on, if it doesn't go well managed, it can actually create another focus, at which point the person would no longer be a good surgery candidate. So the earlier they're referred to an epilepsy center, the better the outcome.
Any other questions? Okay. Anything to add?
Well, thanks for coming, everybody.
We have